Hello, my name is Niels van der Donk, and I presented at EHA an update from the patients that were treated with Talquetamab plus Daratumumab in the TRIM2 study. In the TRIM2 study, there are multiple cohorts. Patients can be treated with TAG plus Dara, Tal+Dara. There are also cohorts where an IMiD, like pomalidomide, is added to the TAG plus Tal plus Dara combinations. But here at EHA, I presented the data from patients treated with Talquetamab and Daratumumab. In our lab, we have shown that there is a strong rationale for combining Dara and a bispecific antibody. We have shown that regulatory T cells confer resistance to bispecifics, and Daratumumab is able to eradicate those CD38 positive immune suppressor cells, such as Tregs, Bregs, and MDSCs. And by doing so, T cells increase in numbers and have also better killing capacity. And that may explain why in vitro assays, Daratumumab enhanced the killing efficacy of bispecifics such as Talquetamab. So in the TRIM2 study, Daratumumab was given subcutaneously to heavily pretreated patients according to the approved schedule, and there were multiple cohorts whereby Talquetamab was given in a different administration schedule. I presented two cohorts. The first cohort was with 800 mg per kg Talquetamab given every 2 weeks subcutaneously, and the other cohort was with Talquetamab 400 microgram per kilogram every week given subcutaneously. Importantly, pre-medications were only given during step-up dosing and the first full dose and could be stopped thereafter. So patients were heavily pretreated in both cohorts with 5 to 6 prior lines of therapy. Anti-CD38 refractory disease was present in a majority of the patients. Approximately 2/4 of the patients had CD38 refractory disease at the time of enrollment. Triple class refractory disease was present in approximately half to 2/3 of the patients, and pentadrug refractory disease in 1/3 of the patients. Importantly, half of the patients had received prior BCMA targeted therapy. So this is a very heavily pretreated population. So I first presented some toxicity data, and what we see is Tal and Dara was tolerable, and there were no overlapping toxicities observed. Cytopenias were mainly seen during the first 2 cycles and resolved in the majority of the patients. And as with other Talquetamab studies, we see cytokine release syndrome in 70% of the patients, mostly grade 1 or grade 2. And we do see some oral toxicities like dysgeusia, loss of taste or altered taste. And also we see skin toxicities and nail disorders. But these can typically be managed well with either topical creams or mouthwash, and sometimes for grade 3 rash, systemic steroids were given. The response rates across the whole, across both cohorts of patients was 80%, including VGPR or better in 62% and CR or better in 29%. The overall response rate in the patients that were previously exposed to anti-CD38 therapy was 77%, and there were also a small number of patients that were either Daratumumab naive or Daratumumab sensitive. And in these patients, 8 patients in total, the response rate with Tal and Dara was 100%. And also in the patients with previous BCMA exposure, we saw similar response rate of approximately 75%. And this was observed in both CAR-T patients, patients with prior BCMA bispecific, and patients with prior BCMA antibody drug conjugate. Follow-up was 6.5 months in the responders. And with that follow-up, 90% of the responders were still on treatment and alive. And I think that's also an encouraging signal of this doublet. So in conclusion, data from TRIM2, the Tal+Dara cohort, support the use of this combination as a novel immunotherapy-based approach for the treatment of patients with anti-CD38 exposed myeloma. The combination appears to be safe with a safety profile that was consistent with each agent given as a monotherapy. Preliminary efficacy data suggest a promising response rate in heavily pretreated patients, the majority of whom are anti-CD38 refractory. And the efficacy of Tal and Dara suggests that higher response rates may be observed in patients who are not refractory to anti-CD38 treatment. Again, in the 8 patients that were Dara naive or sensitive, we see a 100% response rate. And there are several studies evaluating other Talquetamab-based combinations.